All right. Good morning, good afternoon, good evening to all of our colleagues logging in from Australasia and around the world. Thank you for joining us today for another session of TAPS, the Australasian Pleural Seminars, our monthly pleural series. Remember to please mute your microphones and then enter any questions you have in the chat box we can review at the end of the talk. Lastly, if you're not able to join us in real time, please remember that these seminars are recorded. They're uploaded on YouTube to watch at your leisure. And so without further ado, I have the privilege of introducing Dr. Deirdre Fitzgerald. She's a respiratory consultant at Tallaght University in Dublin, where she has set up the first pleural service in Ireland. She completed her PhD in pleural disease here at Perth at Sir Charles Gairdner Hospital. And during her time here, she published around 20 papers and reviews, quite busy. She's gone on to speak at international conferences, and she's actually, you might recognize her name for helping develop ERS guidelines in managing a pleural disease. And speaking of her publications, among the many that she has, they're relevant to today's topic. She was actually the co-author of the PLEASE study and the lead author of the PLEASE 2 study, which evaluated breathlessness and pleural effusion. So we're excited to have her on the series here today to discuss how pleural effusions cause breathlessness. So Deirdre, please take it from here.
Thank you so much for that kind introduction. Just checking that you can see my slides.
Absolutely.
So I'm delighted to be here today to talk about how pleural effusion causes breathlessness. And over the next 15 minutes, we're going to talk a little bit about the importance of breathlessness in pleural effusion, about the measurement of breathlessness in pleural effusion, the pathophysiology that underlies how the breathlessness occurs, and a bit about the predictors that might exist in how we can see who will benefit from drainage of the effusion. And breathlessness is extremely important in pleural effusion because it's the most common reported symptom, and it can often be debilitating and severely impair patients' quality of life. And as we know, patients with malignant pleural effusion in particular have a very poor survival. That's the survival curve taken from the Lens study. But also we know that non-malignant pleural effusion, sometimes called benign pleural effusion, which is often really a misnomer, given that the survival is also quite poor and is around 50% at 12 months for transudative effusions, for example. We also know that breathlessness is a predictor of survival, and this is work from Eleanor Mishra, in which she looked at took VAS scores taken from a number of randomized control trials and showed that for a lower VAS score, the survival was better. This is at the time of diagnosis, but as you increase your VAS score, i.e. develop more breathlessness at the time of presentation, your survival is actually lower. So how do we measure breathlessness? And it is quite difficult because it's quite a heterogeneous symptom. Some people complain of chest tightness. Some people have respiratory muscle fatigue and air hunger. And altogether, those combine to give you a subjective feeling of breathing discomfort. But that's also affected by pain, by frailty, and by psychosocial issues. So it can be hard to measure, and we need to find a valid test. So the most common test that's used in most of the studies that we've done so far has been a VAS dyspnea score. And this is generally a 100 millimeter line that goes from no breathlessness to worst breathing imaginable. And what we can say about the VAS score is that it is interpretable. And these are all the parameters that we need for a test to be valid. So it is interpretable in that we can understand what it means. It's precise as it's a continuous variable. We can pick any spot along the line. And it is responsive, and we've seen that again work from Eleanor Mishra in 2015, published on the development of an MCID for VAS dyspnea. So we know that it is responsive to drainage and other interventions. It's also feasible. It's quite easy for a patient to fill in, unlike things like an exercise walking test, which might be difficult for someone who's quite frail. And we know that it's acceptable to patients because we have seen good response rates to with minimal missing data in randomized control trials using a VAS dyspnea score. In the future, wearables are becoming much more common. This is an example of an actigraph that's been shown to also be quite feasible and acceptable as a measure of functional ability in malignant pleural disease, but it's not as easy to use as a VAS score at the moment and hasn't replaced it. So what about the pathophysiology of breathlessness? Well, many people would say it seems quite logical. If you have a large pleural effusion, such as this one, then it's going to compress the lung and reduce the lung volumes. if you have atelectatic lung floating in your pleural effusion, surely you'll develop some degree of shunt and therefore hypoxia as a cause of the breathlessness. But as usual, it's not that easy. And this is a table that I've taken from Sanjeevan Muruganandan's PhD, in which he looked at all of the different studies of physiology of breathlessness over the last number of years, looking at muscle strength, gas exchange, respiratory system compliance, mechanics. And what I can tell you from this is that most of the findings that he summarized so neatly in his PhD thesis support the findings of PLEASE-1, which is the study that he led. So I'm going to focus predominantly on PLEASE-1 at the moment. So PLEASE was the pleural effusion and symptom evaluation study that enrolled 150 patients, making it the largest physiology study so far. And we performed a range of assessments pre and post drainage. So I can tell you, first of all, that not surprisingly, the VAS score, which is the VAS breathlessness score, improved post drainage, as did your 6-minute walk distance on the second panel on the right. And on the bottom two panels, you can see there was an improvement in quality of life. And no one was terribly surprised by those results. But then we looked at the change in vital signs post-drainage. And what we found was that if you compare oxygen saturations pre and post-drainage, there was no difference whatsoever. And if you look at heart rate and respiratory rate, both had a statistically significant improvement, but whether that small change was clinically significant is not as clear. We also looked at change in lung volume post-drainage using FVC as our measure, and I've summarized that here with a number of the other trials that have been done over the years. Some studies have used TLC as well, but more used FVC. And what we can see is that there was a definite improvement in your FVC in each of those studies, ranging from about 200 to 400 mils in general. But there was a drastically more significant decrease in your chest volume in terms of your volume drained. So the volume of fluid drained was generally 1.2 to 1.8 liters, which is obviously a lot more compared to the modest increase you see in your FVC. So why are patients breathless? And the theory is that altered respiratory mechanics occur due to pleural cavity expansion. And you can imagine looking at this CT scan, how this patient would have significant breathlessness. And the theory is that when the chest wall is expanded due to the volume of fluid that's present, you get an impairment of the chest wall contraction because the muscles because the chest wall muscles are shortened and therefore they're not able to develop as much tension. So Esten et al., who produced a very nice paper based on 9 patients back in 1983, showed that they believe that the muscles are trying to contract along a suboptimal portion of the length tension curve where the initial C is here on the vertical slope. And so they're not able to generate as much tension. Whereas if we drain the effusion and allow the muscles to lengthen, that they can contract on a more optimal part of their length tension curve. So drainage of the effusion removes the weight from the hemidiaphragm and from the intercostal muscles and restores the respiratory mechanics. And at those in the 80s and 90s, a lot of these tests had to be done using transpleural pressures, using esophageal and gastric balloons. What we can do nowadays is use ultrasound to assess the diaphragm. And we can do that in a qualitative way, looking at the shape and movement of the diaphragm. So this video demonstrates a very flattened hemidiaphragm, which is moving up during attempted inspiration, which is paradoxical. And we can also perform quantitative assessment. So this is the first panel here shows it's actually my diaphragm, and you can see the bright white line of the diaphragm moving towards my probe, which is looking upwards from below the liver. And you can see that it generates a wave underneath, which can be measured in centimeters. And that's the diaphragmatic excursion during that will be deep breathing. And we can also look at the thickening of the diaphragm. So the diaphragm thickens on inspiration and thins on expiration, as you can see here. Furthermore, we can look at paradoxical movement of the diaphragm. This is a normal diaphragm during a sniff procedure, and you can see the deflection of the wave is towards the probe. Whereas if you have a pleural effusion, the weight of the diaphragm can cause paradoxical movement of the diaphragm on sniff, and you can see that the wave is inverted. So Paradoxical movement was studied by Wang et al. In 2007, and what they found was that your Borg score significantly improved post-drainage if you had paradoxical movement and did not improve if you had normal movement of the diaphragm. And further to this, in the PLEASE study, we also found that you're 4 times more likely to respond if diaphragmatic dysfunction was seen pre-drainage. And all of this comes back possibly to neural respiratory drive. So neural respiratory drive is the neural impulse that stimulates your inspiratory muscles. And there's a theory that we have an efferent-afferent mismatch if you're not getting as much gain from your neural input as you expect. And this is 2 graphs taken from a COPD study just to show that your EMG diaphragm, so that Carolyn Jolly used EMG of the diaphragm, and she assessed it over time over exercise. And what you can see is that your EMG diaphragm goes up, which is a representation of, or a surrogate for, neural respiratory drive, whereas your tidal volume plateaued after a certain level, but your breathlessness continued to rise. So this is considered to be reflective of neuroventilatory uncoupling, and an awareness. They believe that an awareness of neural respiratory drive is what causes the breathlessness. And Deepan Sivakumar has looked at this in the SIGN study. So they looked at 8 patients and measured parasternal EMG pre and post drainage among a number of other physiological measures. And what they found was that your EMG of your parasternal muscles certainly decreased, and there was a trend towards a decrease in the EMG power percent max, which is how you normalize the value. And there was also a trend towards a decrease in your neural respiratory drive, which they took as a function of the EMG power percent max and the respiratory rate. So in summary, it appears that your neural respiratory drive is high pre-drainage and reduces post-drainage. And they also found that this correlated strongly with the change in VAS post-drainage. So perhaps if we have a high neural respiratory drive, we can expect that this is a cause of the breathlessness. So if you get this neuroventilatory uncoupling, you get less bang for your buck, and you get a low, or as Sten put it in 1983, a low gain in converting a given neural input into a mechanical output. But maybe that drive goes elsewhere, and that's what led us to the PLEASE 2 study. So in the PLEASE 2 study, we looked at both the ipsilateral hemidiaphragm pre-drainage, which moved less than would be expected, and normalized post-drainage. And we also looked at the contralateral hemidiaphragm and found that the excursion pre-drainage was significantly more than normal reported values, and also normalized post-drainage. And those were inversely proportional to each other. So the more impaired your ipsilateral hemidiaphragm was, the less, or the more your contralateral hemidiaphragm moved. And this was also seen by Kevin Blythe's group, Dr. J.S. Kera in Scotland, and they looked at 4D MRI of the diaphragm, and they found that post-drainage diaphragm curvature height was higher in your ipsilateral hemidiaphragm, but they also looked at the contralateral hemidiaphragm and found that your diaphragm curvature height was reduced post-drainage. It was high before and reduced post-drainage, again suggesting that the contralateral hemidiaphragm is doing more work pre-drainage. And whether that's reflective of the increased neural respiratory drive or a compensatory mechanism is to be confirmed. We also know that not all patients respond to drainage, and in the PLEASE study, we found that over a quarter didn't respond. That's based on your VAS CID, and we found similar numbers in the PLEASE 2 study. And what we want really is to identify a predictor that will tell us who will benefit before we do the drainage procedure. So Wang et al., again, as I mentioned earlier, noticed that patients with paradoxical movement of the diaphragm had improvements in SpO2, FVC, AA gradient, and Borg score, whereas the patients with no paradoxical movement didn't show those improvements. Now, I wouldn't use the absence of paradoxical movement as a reason not to drain an effusion. Going on from there, Luke Garska looked at this in 2019, and they performed a baseline dyspnea index in which a lower score is worse, and they found it was lower in patients with abnormal diaphragm and tended to improve more in patients with abnormal diaphragm. So again, the diaphragm seems to be a major factor. In the PLEASE 1 study, there were a number of factors identified, including predominantly more severe dyspnea was a predictor of improvement, but also abnormal diaphragm movement, as I mentioned, and benign etiology, higher pleural fluid pH, and higher serum albumin. And a model that was combined all of those variables, gave the best predictive value, but it still was not felt to be sufficiently accurate to be applied clinically. And a model using the breathlessness alone was almost as good as using the combined model. So really, a self-reported severity can be a simple and useful tool in determining if drainage is to be recommended, and VAS score is probably the best thing we have at present. Just to highlight that based on all of the PLEASE data, we can say that if someone does have abnormal SATs or abnormal heart rate, it is important to consider an alternative diagnosis, such as a pulmonary embolism. And also, if they have normal vital signs, that definitely doesn't mean that they won't benefit from drainage, and breathlessness should be our main motivator. Lastly, we did hear a number of times over in clinics that patients come in saying, "Doctor, I can't tie my shoes anymore." And that led to the hypothesis that bendopnea or breathlessness bending over might be a useful predictor of response to drainage. And PLEASE 3 is in progress, and I'm told that some of the results will be presented at ERS, but I was not privy to those results just yet. So we'll have to tune in to the Pleural talk from Professor Lee. So in conclusion, what we can say at the moment is that VAS is the best measure of breathlessness that we have, although it is subjective, and an alternative objective measure would be better. VAS score can be considered a simple and useful measure to predict drainage benefit until we have, again, a more objective measure available. And I believe that further evaluation of the diaphragm and pre-drainage measurement of neurorespiratory drive may provide a better insight into the mechanisms and a prediction of drainage benefit. And there are further studies, again, following the SIGN study, that will hopefully give us more information on all of that. Thank you.
Awesome. Thank you so much for that. That was really enlightening. I think while we wait for some questions to come in, I'll start with a question for you. So in patients, you mentioned the VAS score and ultrasound findings that you can kind of take a look at, but patients that were considering doing a procedure, would you recommend doing a thoracentesis to evaluate if there's any dyspnea improvement before we do something, more definitive, like an indwelling pleural catheter or anything like that?
I think it definitely depends on the scenario, but as we've seen from all of the studies to date, your VAS dyspnea score is your best predictor. So if a patient is breathless, and especially but not limited to those who have abnormal diaphragmatic movement on ultrasound, then I would be happy to proceed with a more definitive measure and save them the initial thoracentesis. I think it's rare that in those situations you don't see an improvement in breathlessness. But obviously, again, in those patients who have smaller effusion, and if they have any other impairment, such as hypoxia, or if they're very tachypneic, then I would be considering doing other investigations looking for an alternative diagnosis, because the effusion is rarely the cause of those impaired physiology.
Gotcha. Yeah, that makes sense. I'll just take a quick peek and see if there's any questions kind of popping up yet at this point. Not. All right. So then the other thing I'll kind of ask you about too is, there are colleagues at Vanderbilt, relatively recently published the Gravitas study, and that was just looking at technique of pleural drainage, versus gravity versus manual aspiration. So when the primary indication is for therapeutic purposes of relieving breathlessness, do you have kind of thoughts on how you like to approach it? Are you a gravity drainage, manual aspiration, any benefits or thoughts on how you like to do it?
I have never had a problem with doing aspiration, and I definitely think it speeds up the process. What I would typically do is, if I'm putting in a thoracentesis catheter, I'll put it in, take my samples, which you just always need to make sure we take enough volume for samples. And then while I'm maybe clearing up and that, I might leave it on gravity drainage. If it's flowing freely and a sizable volume comes out, then I would leave it at that. But if I need to, I'll happily aspirate.
Yeah.
Using a 3-way tap.
Perfect. All right. So let's
Luke Garska's comment. What does it?
Yeah, we get some questions here. So I'll start. So in the studies, did you ask the patient to describe severity of dyspnea when discussing the VAS score? They're asking, in your studies, did you ask the patient to describe severity of dyspnea in daily activity or with exercise?
It was a measure of just an average over the preceding, I think it was over the preceding week. I've got me there about the timeline, but no, it was just general activities, not necessarily on exercise. And I think that is probably one of the factors that Eleanor Mishra highlighted and Sanjeevan in their review paper, is that you are talking to a group of people often who are very frail and who aren't getting much exercise. And we've seen that as well from work from Carolyn Bedell-McIntyre, who looked at actigraphy in patients with malignant effusion. And really what they found was that their activity is extremely limited, that they're sedentary a lot of the time. So if you're trying to ask these patients what they're like on exercise, you may not, they may not be able to describe that. And they're so breathless on minimal exertion that just their average is probably adequate. And you really need like a measurement of breathlessness. You need it to be, I guess, applicable to all comers, so that we can do comparative assessment. So I think that's why, for example, a Borg score on exercise is less useful in these patients maybe than just a general VAS score.
Sure. And just a little bit from the same person asking in terms of the VAS score, is saying some patients seem to find numeric rating scales easier to understand, and there's some evidence that they can be a bit more repeatable in other patient populations. And your thoughts, is there more research needed on measurement of dyspnea, or do you think the VAS score is kind of the way to go?
I did, in looking over all the data to date, I did notice that the repeatability is obviously a limitation, and I certainly know that there is some frustration and I've had this recently where I had a patient who the initial, often they won't recognize how breathless they are pre-drainage. And we see that a lot in patients who've been breathless for months, and they come in and they say, no, I'm okay. And they mark their VAS score, and they maybe give it we'll say 40. And then they have the drainage and they come in the next day and they say, oh my gosh, I feel so much better. And then they mark it 60. And you're scratching your head thinking, how can we prove a benefit if this is so? I think it's extremely subjective. I think that it's probably the repeatability is a limitation because and if you give them a logbook, they can see their previous scores, so it's hard to judge if it's so one of the aspects is in the ample trial and in those ones where we had logbooks, it was fairly consistent, just eyeballing it, but that those patients are exposed to their previous scores, so that's probably going to influence them. And there's a lot of the anchoring philosophy that's there. If you give someone a number, they'll stick around that number. So I think personally that wearables are becoming much more commonly used in COPD and in a lot of other studies. So I think possibly those would become more beneficial and more objective measures in the future. We just need to figure out which one is the best one and how best to use it.
Yeah, absolutely. Another question for you is the volumes of fluid drained in the study were quite high. How do you interpret the patients who are having smaller volumes of drainage but finding subjective or functional improvement? That's coming from Lokesh.
I think also first of all, I think having a procedure done is sometimes a placebo. I had a patient who got much better after having 40 mils drained recently. But I do think, there's definitely, and this is anecdotal rather than evidence-based, but I have seen patients who I've only drained 400 mils, but it's clearly under pressure. And it's definitely, maybe it's to do with also the thickening of the pleura and that the lung, can't expand in a certain way. But I've definitely seen people with lower volumes who have a significant benefit. And I suppose in those patients, perhaps we do perform a thoracentesis initially to see if they get a benefit. At the same time, actually putting in, if you really think that they're very breathless, putting in an IPC isn't that big of a procedure. So if there's someone who's very, if they're definitely palliative, if you want to save them coming back into hospital, and that even in the context of a small effusion, if they're very breathless, I would go ahead. I think the thing we've shown over and over again is that volume drained is not definitive for breathlessness relief. if that makes sense. So say, for example, patients who have hepatic hydrothorax, I mean, I've drained 1,600 mils in a therapeutic aspirate from patients with hepatic hydrothorax, and they don't seem to notice as much because their chest expands so much. Whereas in malignant pleural effusion, it seems to be more like smaller effusions can cause that level of dyspnea.
And then kind of along the similar lines, next question is, how about those patients with trapped lung or non-expandable lung? Any suggestions who would benefit from intervention? How do you kind of monitor or kind of assess them?
So I probably in the same way, I think what we've proven over and over again in more recent studies is that patients with trapped lung definitely get a breathlessness improvement. And if anything, I didn't mention it in this talk, but that would prove even more that it's the impairment of the muscle in respiratory muscle dynamics that's probably the cause of the breathlessness rather than anything else. I would approach it in the same way if they're very breathless, if it's if it's weighing on the diaphragm. And in the future, I suppose what I would like to see, I think would be really exciting. So in DPAN's study in the UK, I think they used balloons to measure pressures and needle EMG, but I think there are now surface EMG. And I just wonder if we did parasternal surface EMG on all these patients pre and post drainage, and we measured their neurorespiratory drive, would that tell us straight off the bat who's going to benefit? I think that's probably the way to go, and I think that study will come out from the UK in the near future. So sorry, back to the point. In trapped lung, I would approach it the same way as I approach anyone else, really. Whether I think the use of ultrasound, I think in the future we will be using ultrasound to more clearly identify who has trapped lung pre-drainage, and what that will change for me is not anything really to do with whether or not I drain them. It would be what approach I use. So I wouldn't offer them an ICC if they have trapped lung on ultrasound pre-drainage. I go straight to IPC.
Sure. Makes sense. Another question we have is, can you see non-drainage therapeutic opportunities to improve dyspnea?
As in, I suppose, like if someone has a large effusion and we don't drain it, I'm not really sure what the question is, but I mean, there are obviously lots of non-interventional management options. We have a breathlessness clinic in our hospital, and we use handheld fans, have been shown to be of great benefit. Patients feel like oxygen makes them feel better, but we believe that that's the flow of air, and as in COPD. So I have found using handheld fans useful, and then obviously medical interventions. So involving palliative care early. I think the other thing that we know is that having early palliative care involvement, and not just for malignant effusions, but and also, like I say, I think I need to move away from calling them benign effusions, because there really isn't a benign effusion out there, and there's an excess mortality associated with all of these. So early involvement of palliative care and getting that input can definitely be an important aspect of treatment.
Yeah. And I think, something else that is frequently underutilized is pulmonary rehab, or just something to get people moving, right? A lot of these patients are so deconditioned because of their other comorbidities, or just even from, their respiratory disease. They just don't move. And so we know the more you move, the better you do overall, right? So I think that's another aspect that's very underutilized. All right. And then I think we'll have time for one last question here. And it is that, do you think whether the rest of the lung has gliding may impact or influence fluid-related breathlessness?
The short answer is no, because I think I've definitely seen people who have fully adherent lung, particularly after a VATS, for example, or a Tallaght pleurodesis, and they might have fully adherent lung in the upper parts. But if you have a fluid accumulation, if anything, it reduces the volume of the chest that can expand to allow the lung to allow the fluid to accumulate. So it will probably push down more on the diaphragm. As Gary says, we're just plumbers, really. It's all about just the mechanics of all of this. And if you've got less space to expand, it's going to push more down on the diaphragm. And I've seen many times that causes significant breathlessness. So I don't think pleurodesis reduces the breathlessness.
Yeah, absolutely. Great. Thank you so much for your talk and answering all these questions. That we are at kind of at the half-hour mark here. So what I will say is thank you for everybody tuning in, and please join us next month when we'll have Dr. Ed Fish, who is going to review management of pleural effusion in the ICU. So please join us then, and thank you for coming in today. Thanks, Deirdre.
Thank you so much.